let's discuss hypertensive emergency, which is when someone is presenting with an outrageous blood pressure related to it, such as papilledema due to high intraocular pressures, and retroorbital headaches also related to the super high pressure in the cerebrovasculature. Let's first start with sodium nitroprusside. The compound itself is rather unique. It is essentially an iron molecule surrounded by a bunch of carbons and one nitrogen. All of the carbons are triple bound by nitrogen, and the nitrogen that is bound to iron is bound to a oxygen. So basically the drug is an iron with 5 carbons and 1 nitrogen coming off of it. The 5 carbons are triple bound to a nitrogen, and the 1 nitrogen attached to the iron has a triple bond with oxygen. This is your nitroso group, which is where the name from nitroprusside comes from. The prusside comes from the fact that there's iron in it. So it kind of looks like there's already a nitric oxide ready to go, just chilling right here as our nitroso group. But how do we go about liberating this nitric oxide from the compound structure it exists as? And that is why it is so fast. It's already ready to go. All we have to do is find a way to liberate it. So what happens is that the sodium nitroprusside must bind to oxyhemoglobin. And that way it can release cyanide, methemoglobin, and nitric oxide. Remember, methemoglobinemia is the condition in which hemoglobin has a heme group with an iron and a ferric. So ferric is the 3+ state, while ferrous is the 2+ state. So this is obviously not reduced because it is not as negative as it could be, or closer to negative. So this is the reduced state, and this is the oxidized state because it has lost an electron. The Fe3+ state is a really, really bad situation because it cannot bind oxygen. This makes the oxygen affinity of the other heme groups in the hemoglobin tetramer. Remember, there are 4 heme groups in a hemoglobin molecule. So in the remaining 3 that are not Fe3+, that are actually just Fe2+, will hold on to oxygen much tighter. So they will not release oxygen under the normal conditions of the oxygen hemoglobin dissociation curve. I know this can be kind of confusing, but you just have to think about it in the way that if the Fe3+ molecule cannot bind oxygen, then it cannot facilitate the release of the other oxygen molecules when it reaches the tissues. Remember, when one oxygen molecule is released by hemoglobin, this facilitates the release of the other molecules under normal conditions in which we have Fe2+ iron as part of our hemoglobin tetramer. So we can potentially cause methemoglobinemia by giving someone nitroprusside. What is the treatment for methemoglobinemia? Probably something that will donate an electron to take this Fe3+ back to an Fe2+. What is very rich in electrons and just loves to help us out? Methylene blue. So this is a potential way they could ask you this question. Incorporate very basic fundamental concepts of pharmacology with a pathology such as methemoglobinemia. You must know methemoglobinemia for the hematology section, and incorporating how nitroprusside can cause a methemoglobinemia, because we must create methemoglobin to release the nitroso or nitric oxide component of the nitroprusside molecule to get that instantaneous vasodilation. That's the way that your step 1 test question writers like to think. They like to incorporate concepts from different chapters in the way that you might be able to see it, because the body is one big first aid book. So let's return to the nitric oxide that was liberated from the nitroprusside molecule. So the nitric oxide is eventually liberated. It will induce guanylyl cyclase to produce more cyclic GMP, which we know will liberate protein kinase G. We know that protein kinase G will phosphorylate the IP3 receptor that is present on the sarcoendoplasmic reticulum that has high levels of calcium inside of it, and we will therefore inhibit the stimulation of this IP3 receptor, and subsequent potential release of calcium into the intracytosolic compartment will not occur. All of the nitrovasodilators cause an increase in nitric oxide. Remember that smooth muscle is found in arteries and veins, so when you give someone a nitrovasodilator, you will be causing vascular smooth muscle cell in arteries and in veins to relax. So you not only decrease the afterload, you also decrease the preload because you're causing dilation of the arteries and the veins. Anytime you drop the blood pressure severely like that, you need to be careful that you might activate the baroreceptor reflex. And this is the concept behind giving someone a beta blocker simultaneously with these agents, which is also something that we saw with hydralazine. But hydralazine only vasodilated the pre-capillary arterioles compared to a nitrovasodilator like nitroprusside that targets both the arterioles and the veins. So what else can you tell me about the nitroprusside molecule? Well, we can get some signs of methemoglobinemia because when we give someone nitroprusside, we eventually come up with the resulting cyanide, methemoglobin, and nitric oxide. So the next component that we need to worry about in someone that gets a lot of nitroprusside is the cyanide. And when we talked about the molecule, it was just an iron bound to a nitrogen with a bunch of carbons. What do these carbon to nitrogen groups remind you of? Well, they look like cyanide, because they are basically. So you can liberate cyanide and cause accumulation of that in the blood. So not only do we have to worry about methemoglobinemia, but we also have to worry about causing excess cyanide to circulate in our blood. So cyanide is an inhibitor of which part of the electron transport chain? Remember, the electron transport chain has a bunch of complexes lined up in a row on the mitochondrial membrane. Particularly, the components are facing the matrix, and there are special delivery of electrons via NADH2 and FADH2 to complex 1 and complex 2 respectively. They donate electrons to these complexes, and there's a very important way that they are transported in between complexes, and that is by very important elements that we will discuss in 1 second. So again, there are 4 complexes that are part of the electron transport chain. Thank goodness they named them 1, 2, 3, and 4. Cyanide is a potent inhibitor of the electron transport chain because the target of cyanide is the cytochrome C oxidase. It is the last transporter between complexes. It receives electrons from all of the other complexes. So here we have the coenzyme Q that is transporting electrons from complex 1 that came from NADH and complex 2 that came from FADH to complex 3, and eventually cytochrome C receives all of these electrons, and it helps transport these electrons to a proton that is coming through the ATP synthase, which is part of complex 4, and it takes a half a molecule of oxygen, combines this electron, half a molecule of oxygen, in a proton to make water. So basically, cytochrome C is the last component in the electron transport chain, transfers electron to one oxygen molecule, which is referred to as half of a O2. In addition, you get protons, so you can make your byproduct of water, and you need 2 protons. So can you just kind of imagine here the possibilities for a vignette with someone that comes in with a hypertensive crisis and they get way too much nitroprusside? Board examiners can ask you about the mechanism of action of nitric oxide, or they can take you into the toxicity world and see what you know about methemoglobinemia and cyanide poisoning. In the situation of cyanide poisoning due to excessive nitroprusside, your patient will start to develop signs of cellular hypoxia because we will be inhibiting our electron transport chain, which is an important element of aerobic respiration. So signs such as loss of consciousness, weakness, headache, and confusion will probably be the most likely things you'll see, mainly due to the hypoglycemia that you get from impaired aerobic respiration and the hypoxic damage that can ensue, particularly to places that are very dependent upon glucose and ATP, such as the brain and neurons. Examiners could come at you in so many different ways regarding nitroprusside, so make sure you know this one really, really well. Okay guys, our flash quiz is upon us. Among the calcium channel blockers, which acts most like nitrates in treating angina? Which acts like a beta blocker? So to answer this question, we need to consider a couple of things. Which of the calcium channel blockers are within the dihydropyridine class, which we know prefer the vascular smooth muscle in comparison to myocardial calcium channels? We know the dihydropyridines end in DIPINE, favor the vascular smooth muscle cells over the myocardial calcium channels. And that means that they will probably act most likely like the nitrovasodilators, which we like to give to someone that is an angina because we want to increase the diameter of the coronary vessels to increase flow. So which one acts like a beta blocker? Probably ones that have an effect on calcium channels that are responsible for conductivity in the heart. Remember, a beta blocker blocks the beta-adrenergic receptor, causes a decrease in cyclic AMP, and this leads to a decrease in the activation of the hyperpolarization activated cyclic nucleotide gated channels that are responsible for the intrinsic funny sodium current that causes our baseline depolarization rate. We can mimic this sort of with a calcium channel blocker because we eventually cause a decrease in the amount of intracellular calcium because we block the calcium channels directly, therefore causing a decrease in contractility and also a decrease in the heart rate because the S8 and the AV node are particularly dependent on calcium conductance for their initial upstroke depolarization phase. So the answers are nifedipine, which means that it classifies into the group that we talked about, the dihydropyridines, ends in DIPINE, and verapamil is your classic non-dihydropyridine that you will see asked about on your step 1 exam because it is a classic calcium channel blocker that directly goes for those calcium channels that are found in the myocardium. What about phenoldiprem? It's a rather unique drug. It is also used to treat hypertensive emergencies. I mean unique because we haven't really discussed any physiology yet associated with the receptors that it stimulates. So first let's examine the name, phenoldiprem. Kind of looks like if I add a little bit at the end, it looks like dopamine. So let's just use our imagination so that we can remember that it is a dopamine D1 receptor agonist. It does not cross the blood-brain barrier, so we do not have to worry about any sort of interaction with the dopaminergic type 1 receptors, particularly present in the basal ganglia. It only acts peripherally, and that's only helpful if we can remember where the D1 receptors are peripherally, and the type of intracellular signaling associated with the D1 receptor. So this will serve as an excellent pharmacology review and also physiology review. The D1 dopamine receptor is associated with the GS subunit of the G protein complex, which means that when activated, we always get an increase in cyclic AMP. Anytime you activate GS, you always activate adenyl cyclase and get an increase in cyclic AMP. We definitely know that when we increase intracellular cyclic AMP, we activate protein kinase A, and then we'll go on adding phosphate things. If we activate protein kinase A in vascular smooth muscle cells, we slap a phosphate onto myosin light chain kinase. Now, what does myosin light chain kinase do? Well, when it's phosphorylated, it can't do anything to begin with. Myosin light chain kinase does exactly what the name says. It will act as a kinase and add a phosphate to the light chain of the myosin molecule. If we have a phosphate on there due to this pathway being activated, there is no kinase activity and there is no phosphorylation of the myosin light chain. Therefore, you cannot get any sort of vascular smooth muscle cell contraction, and that means we get system-wide vasodilation. And by system-wide, I mean you better know where these D1 receptors are, and they are in the coronary arteries, the renal arteries, and the splanchnic vascular beds. So this combination causes a humongous drop in blood pressure because all of these vascular beds will vasodilate. And this should make sense because it is one of the drugs used for hypertensive emergency when all things fail. So we want systemic wide vasodilatation. Again, you need to always consider reflex tachycardia anytime you're giving someone a very powerful vasodilator, which we said were hydralazine, nitroprusside, and phenoldiprem, or phenoldipremine is a good way to remember it.